It's an incredible honor to be invited here and to have the opportunity to speak with you today and share with you what I know about the cardiomyopathy associated with Duchenne muscular disease. And I'm going to start out by sending you guys a big hello from the state of Ohio. And this is how we say hello to people outside of our state. We form a line, we say O-H-I-O, and so you may be walking down the street someday if you're in the United States, and if you have an Ohio State t-shirt on, somebody will go, oh, O-H, and your response should be I-O. And just to show you that this is true, this is our ex-president, who we are now mourning his departure, but a little political commentary, but who came to Columbus and demonstrated the O-H-I-O. And for those of you, see, it may happen to you on an Amsterdam street. And just to show you, it actually is something. So now, even if you don't learn anything about cardiomyopathy this afternoon, you've at least learned how to say hello to people from Ohio. So, why are cardiologists interested in caring for patients with neuromuscular disorders? And it's because the heart is a muscle too. So cardiologists are interested in neuromuscular disorders not only to improve the quality and the duration of life in patients with neuromuscular disease, but as well as cardiovascular disease. Many neuromuscular diseases, such as Duchenne, obviously, have an associated cardiomyopathy and vice versa. Understanding the cardiomyopathy associated with DMD will likely improve the understanding of DMD skeletal muscle disease as well, and this will ultimately improve the duration and quality of life for our patients. Oops, hang on. So I think this is a really interesting slide, and it correlates with one we saw earlier today, in that the interest in Duchenne cardiomyopathy has experienced an exponential increase. And I took this from PubMed, where we're looking at the numbers of papers published since the 1960s, and you can see that there actually now is a pretty significant rate of publication for patients for papers in Duchenne. Oops. So some of the topics that I'm going to be discussing this afternoon, we'll start with the current cardiac standards of care, cardiac magnetic resonance imaging, new insights into chest pain, novel treatments employing cardiac devices, and the cardiomyopathy in female carriers. So as we've seen throughout the day, this paper and these series of papers, these 3 papers published in Lancet Neurology, are important with regards to defining standards of care. And in the second part, there's significant cardiac recommendations, which are, as we've seen from the talk this morning, there's a table outlining all the cardiac recommendations, and I really do encourage you to download these papers and take a look at them. I think despite the fact that they're not evidence-based, they are consensus documents, and even though there are not a total agreement within the field about many of these things, I think they provide you a good framework in which to base management decisions. I won't go through this in exquisite detail because of time, and you can read it on your own, but what I would like to do is summarize. I am really touchy on this. Summarize what they say. Essentially, they're sort of common sense management decisions, things that I think are not sort of what we call rocket science. So cardiology should be involved at diagnosis. Since this is a very severe cardiomyopathy as the patient gets older, I think it's really important that that relationship be established early on. Yearly evaluation should occur while the patient's asymptomatic, and that should include EKG and cardiac imaging, and the preferred cardiac imaging modality at this point in time is cardiac MRI, and we'll see why later on in the talk. We'd also like to say that the visits for the patient should increase in frequency as the symptoms progress or develop. You know, we can't really say you should see the patient at age 12 every 3 months, but what we can say is let your cardiologist be the guide with regards to making those decisions. ACE inhibitors should be started by the age of 10. I think there's a lot of play in this decision too, but I think it's a nice guideline or a benchmark to put in there. And cardiac evaluation should occur before major surgery, and female carriers should also be evaluated, which we'll talk about in a little bit greater detail. So cardiac imaging is revealing a great deal about the disease. And it's important because it helps us to understand the natural history of the disease. As imaging modalities improve, we see that we see this disease with new eyes. In the era of echocardiography, we thought that cardiomyopathy was not present until the late teenage years. And now we know that with cardiac MRI that the disease is present much earlier than we ever thought before. And this improved understanding will not only guide clinical care, but it will provide us with better clinical trial endpoints. All right. Okay, there we go. Excuse me. Oh, you know what? I pushed it too much. I don't know what I'm doing wrong here. I got to go back one more. Can I go back one more? No. There we go. Okay. So I think this is a really important slide, and for several reasons. And one of my goals here is to convince you that cardiac MRI is a better modality than echocardiography. And echocardiography is a really useful tool. I am an echocardiographer, but I think in Duchenne muscular dystrophy it has its limitations. All three of the upper panels there are from just a normal child who, without Duchenne muscular dystrophy, who came into our clinic, and you can see the wall margins and the definition of the myocardium. But in the bottom three panels, you can see this is from a 10-year-old patient with Duchenne muscular dystrophy. And because of the issues with regards to scoliosis and positioning and lungs and airways, it's oftentimes very difficult to get good cardiac data from echocardiography. So we really need a better modality, and cardiac MRI offers that. So the image quality is poor in many of these patients, and these suboptimal images then will result in poor clinical decision making and poor clinical trial data, which I think is important. So cardiac MRI offers advantages in the Duchenne and Becker muscular dystrophy patient. And you can see the images from the cardiac MRI here, which are substantially better than the echo images, which you saw in the previous panels. It lacks radiation exposure. It provides detailed information regarding all kinds of cardiac measures. The disadvantages, however, is that it requires an IV placement. That can have longer scan times. Sometimes pediatric patients are not cooperative, but we've really been working on that with regards to having child life people down in the cardiac MRI scanner. We have goggles that the kids wear that they can watch movies. And so we're really working hard to try to lower the age limit that we can get these studies without cardiac anesthesia. And we're now down to about the 5 to 6 year old patient. The other disadvantage is that oftentimes there's lack of global availability. Some centers are yet to develop their cardiac MRI capabilities, which can be a problem. And if I leave you with one other key concept this afternoon, beside the how to say hello to people in Ohio, it's this slide here. This is really important. So the cardiomyopathy in Duchenne muscular dystrophy is characterized by extensive subepicardial fibrosis. And in the frame, on the left, you can see a past specimen where you can see that white fibrosis or myocardial scar, and it occurs in the subepicardial area, which is very different than you get in ischemic cardiomyopathies or cardiomyopathies as a result of coronary artery disease, which occurs in a subendocardial distribution. And on the past slide on the right, you can also see that blue fibrous staining as well. And this is important because this is what we see on cardiac MRI. So the subepicardial fibrosis is easily identified on cardiac MRI, as you can see pointed to by the red arrow here. The fibrosis starts in the subepicardial area in the basolateral or infralateral wall, and then progresses to the apex and then to the septum. So it progresses in a very characteristic fashion, which allows us to sort of track the disease progression. Importantly, it's present prior to the decline of LV function and early in the disease. Of note, the subepicardial enhancement is also seen in myocarditis, which I think is kind of fascinating. And in myocarditis represents an inflammatory infiltrate. And this, I think, begs the question, are similar pathophysiological mechanisms at work both in Duchenne and in myocarditis? And here's just a slide taken from a paper in 2004 where you can see in the top slices of the heart there that the disease progresses sort of from the posterior basal regions up through the septum, and that with the disease progression, the function declines. So we actually looked at the natural history of the myocardial disease by cardiac MRI in our patient population. We looked at 314 patients. And what we found was that 17% of the patients less than 10 years of age had myocardial fibrosis, with the youngest patient being 6 years. So that's redefining sort of the natural history of the disease by using a different tool. Because previously, as we know, echocardiography said the disease wasn't present till late in the teenage years. 34% of the patients had fibrosis between the ages of 10 and 15 years, and 60% greater than 15 years. 30% of our patients with fibrosis had normal cardiac function, and 84% with fibrosis had 30% of our patients had normal cardiac function, and 84% with abnormal cardiac function. So utilizing cardiac MRI can help us look at common problems differently. And the problem that we actually recently have explored was with chest pain, pediatric chest pain. So chest pain in the Duchenne patient is frequent and typically attributed to the musculoskeletal system. It's often dismissed in a pediatric emergency room, and formal cardiac evaluation is rarely undertaken. The EKG is sometimes obtained in these patients, and a troponin I is rarely obtained. For those of you who are not familiar, troponin I is a sensitive and reliable marker of cardiac muscle tissue injury, and it's normal or minimally elevated at baseline in Duchenne. So in patients with Duchenne, if you look at all comers, you can see sometimes some very mild elevations. A normal troponin is 0.04. And some mild elevations can occur up to 0.1. It's not thought to be predictive of disease progression. So we actually asked the question. It turns out that when we were traveling to a number of meetings and getting together, people would say, yeah, I've seen these troponin elevations in our boys with Duchenne, and I've seen them too, and I've seen them too, and what do you think they mean? And as a result of the generosity of Parent Project Muscular Dystrophy, we put together a meeting of cardiologists in the United States about now 2 years ago to ask the question, what do these troponins mean in Duchenne muscular dystrophy? So what we wanted to do is we had all our centers come and we presented all this data and we had extensive discussions and we wanted to put together a multi-center case report. It became a little difficult and we wanted to get it out in a timely fashion because of all the institutional IRBs and regulations that we had to go through. So we just decided to just publish our own case series, which we did. So we looked at 8 of our patients that were at our institution from 2013 to 2017 who presented with acute chest pain and transient elevations of troponin. The average age of these kids were 15 years, but they ranged in age from 9 to 23. On some of their clinical characteristics included 8 of those patients had acute chest pain with EKG changes and elevation of troponin. And the EKG just demonstrated diffuse ST segment elevation, but it wasn't the type of ST segment elevation that you see in a patient who's had a myocardial infarction. And so it wasn't consistent with coronary ischemia. 5 of the 8 had no other illnesses. 3 of the 8 had other concurrent illnesses, which included pneumonia, gastroenteritis, and sepsis. 8 of the 8 were on ACE inhibitors, and 5 of the 8 were on steroids. So these are the time courses of each of the 8 patients. And you can see that 7 of the 8 patients had troponins elevated on admission and normalized within 4 days. So if this patient had come in to your clinic a week later and said, you know, a week ago I had some chest pain, you would probably would have missed the troponin elevation. 1 of the 8, however, presented with sepsis and had a late troponin elevation which persisted beyond 200 hours. And in that patient, the mean troponin elevation was 44. So, which is impressive given the fact that these troponin elevations are markedly enlarged, are markedly elevated, and elevated to the point that you'd get admitted to a cardiac intensive care unit because, as I mentioned, the troponin normally is 0.04. So interestingly, we took patient 6 for this talk here, and I wanted to show you what their cardiac MRI looked at like. So at baseline, we actually had baseline cardiac MRI data. It was essentially normal. And then during the acute phase of the event, you can see the red highlighted that myocardial ischemia or the myocardial enhancement that occurred. And then that enhancement persisted at follow-up. So there were acute changes that were associated with this troponin elevation. When we looked at serial ejection fraction measurement by cardiac MRI, you can see that when the patients presented at baseline, they had normal ejection fractions. And then when they presented with acute chest pain in this troponin elevation, their their myocardial function declined, and that myocardial function decline persisted both in the short term and the long term. Interestingly, we also saw that highlighting of that myocardium, or that fibrosis, as we're calling it, not present at baseline, and then at presentation with the chest pain, short term and long term, that fibrosis persisted as well. The clinical course was interesting in these patients. 4 of the 8 patients underwent coronary artery evaluation because we didn't know what this was and we didn't want to miss a coronary event. 2 of the 4 had a cardiac CT and 2 of the 4 had cardiac catheterization, and no coronary artery abnormalities were identified. We actually stopped doing coronary evaluation in the patients when they presented, and now that we're looking more carefully, we're seeing it much more frequently. All viral studies, and we really looked hard, were negative. We didn't know what to do about this, so these patients received supportive care with just traditional cardiac medications, and ongoing follow-up continues on all these patients. So we hypothesize that progression of the DMD-associated cardiomyopathy results in part from episodic myocardial injury rather than exclusively from continuous ongoing injury. So we postulate that there's silent and recurrent events that lead to this cumulative injury in a process that's similar possibly to what occurs in the skeletal muscle. And this suggests a stepwise model of disease progression as opposed to a linear one. It's unknown if there could be any external triggers such as viral infections, psychological stress, other intercurrent illnesses, and the role of inflammatory cytokines, given that 3 of the 8 patients presented with infection, may be important. I also thought this was interesting in that after we were having these discussions amongst cardiologists, I picked up a Journal of Neuromuscular Disorders, and I saw this paper that was published by Joe Cornegie, where he had looked at a 7-month-old golden retriever dog with acute onset of cardiac decompensation consistent with a myocardial infarction. The dog died suddenly at 45 months with induction of anesthesia. His serum biomarkers, including troponin I, were markedly increased. There was echo evidence of regional wall dysfunction, and when they did a cardiac MRI on the dog, there was subepicardial myocardial fibrosis and decreased ejection fraction. The subepicardial fibrosis was present on pathology. So whatever is happening in the boys is also happening in the golden retriever dogs. And so I think that this is an important, unrecognized, recognized, but not completely understood phenomenon. Now let's turn our thoughts to some potential treatments, and I'd like to talk a little bit about cardiac devices in the treatment of Duchenne. And I'm going to explore 2 devices today, one the implantable defibrillator, and the second one will be the left ventricular assist device. So an implantable cardioverter defibrillator is a battery-powered device that's placed under the skin. It monitors heart rate and provides a shock when sustained ventricular tachycardia or ventricular fibrillation is detected. The newer generation ICDs also have a dual pacemaker function, and the pacemaker feature paces the heart when bradycardia is detected. So so then the question is, well, I get asked all the time, why don't we just put an ICD in everyone? Well, ICDs are great when they're needed, but they come with significant complications. So they can prevent sudden death, but they can lead to inappropriate shocks, lead dislodgement, lead failure, and have a significant psychological impact. You can imagine if you're walking around wondering if anytime you have some skipped heartbeats that you're going to get this pretty painful shock. It leads to some significant psychopathology. So what are the indications for ICD placement in Duchenne? Unfortunately, as we hear all the time and we've heard today, there's no significant data to support ICD placement in patients with Duchenne. So we need to look to other patient populations for guidance about when to place these devices. There are several important clinical trials that have been conducted in adults with cardiomyopathy, the first one being the SCUD-HEF trial, or the Sudden Cardiac Death and Heart Failure trial, where ICD therapy reduced overall mortality for both ischemic and non-ischemic cardiomyopathies by 23% compared to placebo. As a result, current Class 1 indications for ICD placements in adults with cardiomyopathy, and this is important, in adults with cardiomyopathy, not patients with Duchenne, are a left ventricular ejection fraction less than 35%, and a New York Heart Functionalist Class 2 or 3. Those are patients with mild or moderate congestive heart failure. And once again, the New York Heart Association functional class was not designed to address heart failure symptoms in patients with neuromuscular disorders. So where does that leave us? So individuals with cardiomyopathy are at risk of sudden death, and ICDs prevent sudden death. So patients with Duchenne develop cardiomyopathy. Therefore, everyone with Duchenne who is symptomatic with an LVEF less than 35% should get an ICD, or should they? So what we really need to know is, what is the incidence of sudden cardiac death in Duchenne muscular dystrophy? Oh, the big black box. So to answer this question, we must know more about what the natural history of rhythm problems are in Duchenne muscular dystrophy. So what do we know? So Villa et al. Retrospectively reviewed 442 Holters of 235 patients over a 4-year period of time. The mean age of those patients was 14 years. So interestingly, in the patients who had left ventricular ejection fractions that were normal, only 2% of those patients developed non-sustained ventricular tachycardia. And there were only 3 deaths in those patients, and they were all non-cardiac in origin. So you go over to the third column where the left ventricular ejection fraction is less than 35%. Unfortunately, he didn't have as many of those patients, but there was 40% of those patients had non-sustained ventricular tachycardia. But in the Duchenne population, none of those patients experienced sudden death. So in some regards, conclusions are that clinically significant Holter recordings were rare in patients with left ventricular ejection fractions greater than 35%. And sudden cardiac death is also rare in patients with ejection fractions that are less than 35%. Holter monitoring has the highest yield in Duchenne patients with dysfunction. So, you know, this helps us with 2 decisions, and it's not a lot of data, mind you, but, you know, we oftentimes put Holter monitors on in the younger patients or in the patients with normal ejection fractions. This data would suggest that that may not be the time to look, and that the time to look actually is with the decline in function, particularly when their ejection fraction falls below 35%. So what is the incidence of sudden death in Duchenne? Well, we're actually in the process of looking at, we've got a sudden cardiac death registry. It's an international ongoing study, and we're more than welcome to have any institution participate if they would like. We've so far to date identified 90 patients with an ejection fraction less than 55% and an average age of 21 years. The average ejection fraction is 37% with a range from 8 to 54%. 14 of those 90 patients had significant arrhythmias, and 9 of those 90 patients had ICDs placed with 0 appropriate fires. I think that's really important. There were no appropriate fires. One of our ICD patients in the registry did die suddenly, and everyone thought, because of the mechanism of death and the way the patient died, that patient had died from an arrhythmia. But so we actually went back and interrogated the device post-mortem, and we found no evidence at the time of death of a tachyarrhythmia, and the death was likely a respiratory event. This suggests that ICD placement for ejection fractions less than 35% may not be indicated, in contrast to adult guidelines. I mean, that's a big statement to make, and I don't want everybody to take that as if I necessarily believe that, but I do think it shows you that the power of the need for investigation and the power of the need for further information before blindly saying that every patient with Duchenne with an ejection fraction less than 35% needs an ICD. So let's now turn to mechanical circulatory support. This is the use of a mechanical pump to support a weakened heart muscle. Ventricular assist devices, or VADs, or support a single weakened ventricle, or a total artificial heart replaces a failing biventricular heart. And there are 3 indications for ventricular assist devices: 1, the bridge to transplant; 2, the bridge to recovery; and 3 is destination therapy. Transplantation is not typically considered an option in Duchenne because of limited donor availability and complex ethical issues. Obviously, patients develop progressive respiratory failure and skeletal myopathy that makes justification for transplantation with a severely limited donor supply difficult. So let's look at some LVAD use in Duchenne. Unfortunately, there are limited case reports in the literature, including the use of VADs in Duchenne. The largest case series, which was 7 patients, was reported out of the Children's Hospital in Rome. They had 6 patients with Duchenne and 1 patient with a beta-sarcoglycan defect. The median age of follow-up in their publication was 21 months, almost 2 years. And they had 3 non-cardiac deaths from the use of the VAD. So, I mean, I think we're learning. We're learning how to use VADs in Duchenne, and I think we're on a pretty steep learning curve at this moment. Challenges exist for the placement of VAD in patients with Duchenne. Multidisciplinary evaluations required. Candidate selection is going to be absolutely critical. There's delayed wound healing secondary to muscle wasting, and device placement must not disrupt diaphragm function. And it's unclear if its use will prolong duration and quality of life. So lastly, let's explore cardiac findings in carriers. So to date, most of the carrier studies have focused on cardiac manifestations. Psychosocial and skeletal muscle disease, unfortunately, has not been extensively studied. It's believed that cardiac abnormalities are not present into adulthood. And the incidence is tremendously variable depending upon the publication. Some echocardiographic studies report an incidence of anywhere from 8 to 38%. There is a single cardiac MRI study where they looked at 36 Duchenne and Becker carriers at age 44. 4% had a reduced LVF and 44% had evidence of fibrosis. And this suggests that carriers may be at a higher risk than previously believed. And it goes back to what tool are we using to ask the questions? And so I think all the information that we have about cardiac involvement in carriers is really colored by the fact that most of these studies have been done through the use of echocardiography, which actually, as hopefully you now understand, may not have been the best tool. So through the generosity of Parent Project Muscular Dystrophy and a very generous grant, we have been able to initiate the female carrier study. The recruitment is currently ongoing. Our aim is to have 100 carriers and 50 non-carriers, but the non-carriers are Duchenne moms, and so I think that's important. All of the patients in our study are Duchenne moms, and we do actually have a control group as well that are normal controls. And we have three areas that we're evaluating: functional skeletal muscle evaluations, psychological evaluations, and cardiac evaluations, which include CMR and exercise testing. So treadmill exercise testing, for those of you who are not familiar with it, is typically used to define the functional capacity in patients, exclude ischemic cardiovascular disease, which is actually not expected to be more prevalent in this patient population. And carriers are highly functional individuals. So it's thought that this treadmill exercise testing will add information beyond the traditional 6-minute walk test, which we expect the moms to do well in. And so hopefully it's going to help us define those with and without manifestations of the disease. So what have we found so far? We're looking at maximal oxygen consumption, and I apologize for this slide. I forgot to take out the animations. But full efforts were given by 100% of participants, and we measured the maximal oxygen consumption, or the VO2. It's recognized as an indication of a person's fitness level. And we found no difference between somatic and non-somatic Duchenne moms with regards to oxygen consumption, which I think is really important. But there was a significant difference between Duchenne moms and controls. So what does this mean? It means that being a Duchenne mom meant that you had a lower general fitness level compared to age-matched control mothers in general. So it wasn't whether you actually were a carrier for the disease, it was whether you actually had a son with Duchenne. And this may speak to the burden of caring for a child with a chronic illness, which I think is really important and speaks to some of the psychosocial impact of the disease. So one other thing that we saw was that PVCs, or premature ventricular contractions, are a marker of myocardial irritability in non-Duchenne-related cardiomyopathy studies. And we did actually notice PVCs during exercise in 50% of the carrier patients. So some preliminary thoughts about the results, or while our Duchenne moms did not appear as physically conditioned as our age-matched control moms, deconditioning is multifactorial and was still at a respectable level. Exercise appears safe also for Duchenne moms. No mom had a cardiac evaluation with either an exercise or cardiac MRI finding that would preclude exercise. And while arrhythmias were more common in carrier moms, they were a very benign type of arrhythmia, and none demonstrated a sustained rhythm abnormality. We have a lot more work to do. But we also looked at their cardiac MRI data, and this is very preliminary data. We've yet to sort of look at all of it at this time. But I think what was important to appreciate is that in the carrier moms, 15% of the moms had left ventricular ejection fractions less than 55%, and many of them did not know that they did, and that there was 50% of the moms had fibrosis. And none of our non-carrier moms actually had lower ejection fractions or fibrosis. So these are very preliminary data to suggest a significant incidence of a low EF and fibrosis at a higher incidence in carrier moms. And we need to better understand the morbidity associated with this being a carrier. So overall, in conclusion, the heart is an important muscle too. Cardiac MR is a valuable and informative tool to evaluate the cardiomyopathy in Duchenne. Chest pain in the Duchenne patient may be a signal of acute cardiac injury, and troponin levels in the presence of acute chest pain should be obtained, as well as an EKG. Cardiac devices have an evolving but uncertain role in the management of Duchenne patients. Carriers may be increased risk for cardiac disease. And finally, I think we can all achieve better patient outcomes with a breakdown of these clinical silos, and we've been addressing some of these issues as the day has been progressing today. I think to have the neuromuscular specialists, nursing, OT, PT, cardiologists, physiologists, all of the people together in one clinic, I think is how we get the best outcomes for these patients. So thank you.
Thank you very much.